Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory.
Hi, everyone. Welcome to Guts and Glory, a series of intuitive podcasts where we delve into complex cases in GI and HPP surgery. Wait, I know you think you've logged on to the wrong channel, but no, this is the same Guts and Glory. But today, for an interesting twist, we're spinning it around and turning the spotlight on the interviewer himself. So, let me just introduce myself. My name is Gayatri Balachandran. I have the privilege of being one of the first DMB GI surgery residents taught by Dr. Sadiq Sikora. And now it's such a special experience for me because being here in this capacity, not just because this is going to be a wonderful discussion, but because of the person whom I have the honor of interviewing. Dr. Sikora is a stalwart in the field of GI and HPP surgery in India. Anyone who is training or has trained in the field knows that he is a leading figure, and his name is synonymous with complex biliary surgery. As his former student, he has profoundly shaped my own journey. I've had the privilege of learning from the best, both inside and outside the OT. And it's a rare and humble moment for me, sir, to be able to sit across the virtual table and interview you. And I'm excited. I can't wait to dive into the conversation and give our audience a glimpse of the wisdom that I was lucky enough to witness firsthand. So, if you're ready, sir.
Thank you very much, Gayatri. So many things you've said. Uh, I can only say thank you very much. Uh, Another time, another occasion, we'll tell you how special you are. So, yeah, I'm excited and I'm looking forward to being grilled by you. And hopefully,
For
we
a
can
change, yes.
come around and have some interesting, insights into this seemingly complex, but not that complex area if you try to make it simple. So, yeah, I'm all ready. Go
Oh,
ahead.
wonderful. So, can we start with you telling us about your journey into surgical gastro? I mean, you established yourself at SGPGI Lucknow, as we know, 30 years ago, more or less. So that was the time where surgical gastro was just emerging as a field. And so, how was it being part of a young department in an evolving field?
Yeah, I think I was lucky, as many people say, that, to be at the right place at the right time. And it sort of fitted clearly as far as my career graph is concerned. So uh, it was a new institution. Uh, Dr. Vinay Kapoor, who was the faculty at All India Institute, where I was the senior resident in surgery, had moved to SGPGI. And I was finishing my senior residency at All India Institute in the Department of Surgery. And he said that, do you want to come to Lucknow? So one of the things my nomadic style started from there on. So I said, yeah, I was not very excited to continue at Ames, and this was a new place, uh, new department, new institution. So and he was going there, so I promptly agreed and I said, I'm going to join you and follow you there as a senior resident. And it was uh, great times actually. To see a department grow right in front of you, and grow with the institution also. It's a special occasion actually, and very few people have that opportunity. So we were a young department, two very bright surgeons leading at the helm of the affairs, Dr. Kapoor and Dr. Rajan Saxena. And we had a great bunch of first time senior residents, all were post MS. So Dr. Love Kakkar, Dr. Ibrar, Dr. Wasif Ali, and all of them, we all were together. And we really were into it, that let's get on and make it
Do
something
some
memorable, the whole
wonderful work. Yeah.
place. Yeah. You rightly said that it was in its infancy, and people were talking that what is surgical gastroenterology? I mean, what is it different from general surgery? And, Dr. Kaushik had a great role to play in establishing that, who was subsequently came as the head of the department a year later at SGPGI. The other interesting thing about SGPGI was the medical gastroenterology unit was headed by Dr. S.R. Naik, and he was a visionary of his time,
Mm.
and he was instrumental in telling that the medical and surgical fraternity of gastroenterology should work together. They are not in isolation.
Separate
They should
entities. Yeah.
be, hand in hand. Yeah, they should work together because he realized very early and wanted to tell all of us that, isolated, you would be again turn into people who are just doing procedures or surgeries isolated. But together, we would treat problems and find solutions to problems. So I think, all in all, it was a great opportunity, and the campus was great. And
Mm.
finally, uh, I was given the option whether I want to do join as an MCH student, or would I like to be on the faculty?
Faculty. Okay.
And, you know, uh, I was tired of doing the studying bit
I
for,
know. I can
for some
relate.
time. So I said, well, I'll appear for the interview for the faculty and we'll see where it leads to. So that's how the whole journey started, and became part of the surgical gastroenterology team at SGPGI.
Okay. So a lot of foresight, I think, to realize, how the field will grow. I think that's tremendous. So, reflecting on your early career, what inspired you to focus on, HPB and specifically biliary surgery? Um, how was the landscape of stricter management different when compared to today?
Yeah, I think, I remember at All India Institute in Department of Surgery, there were 4 units. And
Hmm.
Unit 4 was the glamorous one with Professor BML Kapoor and Dr. Nandi
Hmm.
being there, right? And we were in Unit 1. I mean, I must say, I have no regrets. And as a matter of fact, feel fortunate that I trained in Unit 1 because it was an excellent unit for training. But we
Hmm.
always used to go and look at Unit 4, what's happening and what are the interesting things happening. And in the theater, there would be portal hypertension going on,
Okay.
and there would
Hmm.
be biliary stricture. Professor BML Kapoor would be doing that. And we were, of course, he was a tall man. We were in the periphery, wouldn't see much, but we used to get excited. To be very honest, I saw one or participated in one biliary stricture repair during my tenure at All India Institute in Unit 1.
Okay.
And Dr. L.K. Sharma was kind enough. It was, I think, my final year of senior residency. And there was a biliary fistula, EBF patient. And said, okay, I'll help you with this.
Oh,
He was a uh, different breed altogether. But having said that, later I realized I was feeling thrilled that I've done a biliary fistula surgery. But I realized that it was a fistulojejnostomy that we did actually in that patient. But I
oh.
realized it quite late. I mean, later in the career.
Hmm.
So I went to Lucknow, And then I heard that uh, they had a case of biliary stricture, and Dr. Kapoor invited Professor R.P. Sahi from KGMU to come
Mm.
and help them with the biliary stricture.
Prepare. Mm.
And that just ticked me in the sense that that means this is a field where there is a lot of gap. The expertise is not yet developed, and the concepts are still unclear. This, mind you, in 1990 and towards that time.
Mm.
So I said that, this excites me. I mean, now I can say I thought about this, but I think it just came naturally that this is an area which looks very exciting, which people are troubled. They are
Mm.
in deep, uh, you know,
Need of, yeah.
need of attention to
Mhm.
take care, to correct an iatrogenic problem. And I got interested in that. And of course, the fact that we were seeing so many biliary injuries at SGPGI that naturally, you know, you could
Mm.
drift into that area and sort
Form a
of
niche.
get
Yeah.
involved in that.
Yeah.
So, yeah, I mean, these were the driving forces which pushed me and said that maybe this is an area which I could concentrate on and
Okay.
look at it.
So since you mentioned, so the 90s was when laparoscopy like boomed in India.
Right.
1990, I think, was the first lap chole. And is that when you started seeing these strictures increasingly, or when did so many patients start coming your way?
Yeah, so I mean, Gayatri, 1990 was, I think, Dr. Tempton Udvadia did the first lab
First
only.
lap chole.
And there was one workshop, and we invited him at SDPGI to sort of show us a
Oh,
laparoscopic cholecystectomy. None of us had done it, and none of us had ventured into it, but we had ordered this, mm,
lap
the
set.
equipment and the set
Mhm.
and all that. So he came, he demonstrated, and it was a difficult gallbladder he did. And next day, the patient was sitting, so we were all convinced. But of course, we all were skeptics in that, oh, come on, like, how you can do a cholecystectomy like that, and so on. What we did at that time was, and it is something very interesting. So we had a special consent form drawn. We also said that two consultants would be involved in the cholecystectomy procedure in the initial phases. And we sort of designed all this and said, okay, this is how we are going to embark on this journey of how you do a laparoscopic cholecystectomy. So that's how we did. And for a year and a half, it was very tentative steps which were taken. Then gradually we sort of more confidence was developed into it, and then everyone started doing independently. So yes, that was the time uh, we laparoscopic cholecystectomy came, but no, the injuries were not the result of this. As a matter of fact, we realized, and we also, I think, published in our initial series that the majority of injuries were with open cholecystectomy, which we were dealing with, not lap cholecystectomy. So the problem was even before laparoscopic
Four
cholecystectomy.
lap. Okay, that's
Yes.
interesting. Yeah.
Absolutely, no doubt. And in our large series which we published, there were more patients with open cholecystectomy than laparoscopic cholecystectomy.
So it was always a problem. So out of curiosity, when did you do your first lap chole?
Around that time, I think, see, 91, I came on the faculty. So till that time, I was only assisting. And I think in sometime the end of 91 and beginning of 92, probably I started doing lab cholecystectomy on my own as an independent consultant.
So I have to ask, I mean, laparoscopy's evolved so much and technical prowess is like, jumped by leaps and bounds. We're pushing the barrier. So why do these injuries still occur? I mean, lap chole is probably the most commonly performed procedure, probably the first lap procedure many surgical residents get to do. So shouldn't these injuries be like a thing of the past now that we know about them? Why do they occur, you think?
So to my mind, there are several reasons for that. The first and foremost, I think, still even now, there is uh, not very well organized formal training programs for laparoscopy during the surgical training. So if you have 100 people coming out at surgical trainees after that, out of, say, you assume that number, I think almost 60 to 70% of people would not have had good exposure to laparoscopic surgery. They might have seen some, but have not had any idea of how to do it.
Okay.
And once they become surgeons, they are forced to do it because it's, I mean, if you take a current scenario, it is a norm that laparoscopic cholecystectomy is the standard of care.
Standard of
And
care.
you are
Yeah.
expected to do it. So you just
Mm.
do a few quick courses, you learn and you learn on the job. And because you are doing that, you may land up with problems. So that's the
Mhm.
first thing which I feel. The second thing is that we know that, this uh, visual perception problems in
Mm.
2D laparoscopic vision and functional fixity, which you have. I mean, these are real problems actually, and it has been addressed by Lawrence Way, by Professor Strasberg, and these are real problems. It's not that it is just being talked about in, as a scientific uh, occurrence which happens, but it's a
Mm.
reality. And unfortunately, people don't have a setup where they can immediately have a consultation with an equally, competent person.
Mm.
So if you land up in problems, or even if you're not in a problem, you sometimes uh, end up going in the wrong area. And
Mm.
the concept of timeout and things are not very well established in all places. So, considering all these things, I think those injuries are still occurring.
Mm.
But I must say that we have made a big dent because what I used to see a couple of years back, they are not as
Mm.
many now.
Yeah.
And that indicates that people are doing it better and have learned the subtle nuances. And one of which happens is probably in a difficult scenario or something like that. But I think the more peripheral you go in India, if there are people who have this without adequate training, I suspect that they will continue to have more injury.
So, since you mentioned it, for the benefit of the younger members of the audience, what are your personal tactics to avoid a bile duct injury, especially in the so-called bad cholecystectomies? I mean, what are your go-to strategies?
So even after all these years, believe me, when I go to do a cholecystectomy, I don't go with the idea that, oh, I have to do a cholecystectomy. I mean, I say, oh, I have to do a cholecystectomy. It should not be the one where I mess up today, right? So the first and foremost is never take it lightly because gallbladders will take you from one end of the spectrum to another and will
Yeah,
come
I
out.
remember you used to say there's no such thing as an easy gallbladder.
Yes,
There's no
yes,
such thing. Yeah.
absolutely. So that is the first thing. And I think I, s- I want everyone to go with that, that it's not a simple procedure that you're adding as fillers. It's an
Okay.
important uh, uh,
Standalone surgery in
procedure
itself.
because you would be able to do it, and if everything goes well, it appears that everything is great. But once there is a problem, then you and the patient is in a deep hole.
Mm-hmm.
The second point which I would say is that very early you need to assess that are you going to be able to do a cholecystectomy in a usual manner based on the findings that you have? Usual manner means identify the cystic duct, cystic artery, clip, and remove after
Mm.
identification of all structures. And you find that the callous triangle is frozen, things are difficult, and you need to make a decision quickly. So that
Mm.
part, make an early decision that this is a difficult gallbladder. The second part is I use the bailout strategies very
Mm.
liberally. And when I say liberally means the moment I make an assessment that there is a difficult gallbladder, I plan or my whole uh, approach goes towards how best to do a bailout procedure in this prison. So, as you know, bailout procedures are a big spectrum, but I'm talking mainly of a subtotal cholesterol,
Appropriate.
right? There are many controversies associated with that, and
Mm.
there are very many people who are vocal
Vehemently against. Mm.
against it. That and their arguments are that residual gallbladder is a problem. Their arguments are that it may develop into a gallbladder cancer. And anyway, when you do a subtotal cholesterol, there is bile leakage, which is a problem. My answer to all that and to people who do subtotal cholecystectomy and their support is that, you know, if you save a bile duct, anything else is a small price to pay. It's like
Absolutely. Yeah.
the point is that gallbladder cancer. I mean, I don't know. I've been doing this for so many years.
Mm.
See a cancer in a subtotal cholecystectomy. I'm sure there are instances. I have not seen it in my career. So it may be a possibility,
Wow. Mm.
but in view of or in anticipation of a rare occurrence, you don't want to mess with the bile duct. And
Okay.
with better techniques of closure and suturing, I know personally that our leak rates in subtotal cholecystectomy are not as high as 18 or 20% as is being
Okay.
reported in literature. It would be around 5% or something like that in subtotal cholecystectomies. So keeping all that in mind, I think it's a good option. I always appreciate if I have to do a redo cholecystectomy. I appreciate the people who
Leave
not
alone.
left behind that gallbladder instead of cursing them. I say
Mm.
the individual took a good stand uh, in the best judgment possible at that point of time.
So this concept of safe cholecystectomy, I know, is one of your, labors of love, your pet projects. I've been fortunate to be part of it as well. You've held CMEs.
Yeah.
You've even published a book on the topic. So can you just take us through your work in the area?
So again, I remember one patient, and if you attended my talks and all, these series of pictures would be there of
Mm-hmm.
a ischemic liver, a multiple ducts, and a portal vein rent which I had sewn, and with a disrupted hepaticojejunostomy done by a son-in-law on his mother-in-law.
Mm.
And that image remains to me to
Etched into your
remind
brain.
me all the time that this could be the consequence of a cholecystectomy. So, from that time onwards, and looking at all the bile duct injuries we used to get, um, patients in deep trouble, sepsis, biliary fistula, multiple repairs, and all. So I realized that prevention of this and doing a good, safe cholecystectomy should be. So that's how the interest was generated, and you remember we did the course. So we've
Mm.
designed a course. We have wonderful videos to you know illustrate everything that we are talking about, and it's not just saying. And it went on till COVID. Actually, we did about four
Mm.
courses, and COVID brought a disruption. But COVID also produced the atlas of safe cholecystectomy with Dr. Ibrarullah, who was my colleague and my first colleague at SGPGI actually. He
Okay.
went into the FCH stream and I
I,
joined the faculty. So we are contemporaries. So we published that, and I kind of like the product in
mm,
we are trying to show. I honestly feel that we need a program, national program of safe cholecystectomy. I
mm,
think it is about time that we uh, get the policymakers to pay attention to this, get all the cholecystectomies being, registered.
registered.
Certainly, a bile duct injury should be a reportable event. So
Okay.
that's my uh, goal. Let's
Okay.
see how far we can reach that.
So moving on to a situation if one were to encounter an intraoperative bile duct injury. Um, what would be your suggestions on how to handle it? What is your algorithm for such a situation?
Yeah, I think we know that most of the time they are missed. Only 30% are recognized.
Okay.
So, that's the sad part of bile duct injury that we don't recognize. And most of the time, I have people sending me patients saying, you remember at that time also
Mm,
that, oh, I think it's a leak from the cystic duct. I did a very good cholecystectomy. And when we review that same video, you realize that it is not the
yeah.
cystic duct leak. So if you recognize on the table, I think that's a good scenario, at least, that
Mm,
you know that there is a problem which has occurred. What I would do myself and recommend to others is look at three things.
mm,
First is that whether you are equipped yourself to manage the problem.
okay.
The second part is whether your setup allows you to do, even if you are capable of doing a
Mm,
hepaticostomy. In that, what I mean is, do you have an interventional radiologist? Do you have an intraop cholangiogram facility? And you have loops, fine sutures
instruments.
to
Yeah.
anastomose the undilated ducts.
Mm,
So that's the second part. And third is the anatomy, that how severe is the injury and whether
mm,
it is associated with any vascular injury.
yeah. Mm,
So the first two are easy to make out, that you can make a quick assessment of that. Sometimes it is difficult to know what the type of injury is, and therefore
mm,
cholangiogram is a must once you recognize that there is a problem. If there is a vascular injury, it's very simple. If there's a vascular injury, no repair,
mm,
just drain and come out. If there is a lateral injury, all people who are doing can afford to do a repair, lateral repair, either by laparoscopy or converting to open, right?
mm, mm,
Uh, you may want to do a stenting subsequently if you don't have the facility to do at that point of time.
yeah.
And if it is a complete transaction and the first two things are no, then just put a drain and send the
Okay.
patient to a referral center. Now, this referral has to be quick because if
Mm,
you send early, well in time, it can still undergo a repair. But if it is delayed or if the sepsis ensues,
mm,
then the early repair will go,
okay.
that option will be lost. So, early referral, quick assessment, and judgment whether it can be managed or not. And the same thing applies to if you
Mm,
are in a place where you are operating and somebody calls you for that or
mm,
encounters that. I mean, the setup, it is there, everything is fine. Now you just need to know whether you can assess the level and extent of
mm,
injury. If that is
mm,
sort of suitable, amenable
mm,
to an early repair, do it. Otherwise, you just wait. So I think it's very simple. It shouldn't be made complicated.
mm. And how early is early for you? 48 hours, 72 hours, or is it? condition of the patient, what would you put a time to it?
So you did the seminar on timing of bile duct injury. I remember that. And you know that there is no definition of early or late repair. But in my book, early repair is anything between 24 to 72 hours,
Mm.
provided other caveats are taken care of, which we just highlighted. Anything beyond 72 hours, unless it is a clean clipped duct with no bile leak and no cholangitis, I would attempt beyond 72 hours. But if there is bile leak, if there is any slight evidence of sepsis, I wouldn't attempt an early repair in this. The point to remember is between 2 or 3 weeks to 6 weeks is the worst time to repair universally. I
Oh.
mean, it's been documented in all the
Mm.
literature. So don't attempt that. Then it is all delayed, which
Okay.
is again beyond 6 weeks minimum.
Mm.
It could be anything after that, based on
Okay.
the how the patient's course has been and what has happened to these patients during this period.
Okay.
One thing I want to highlight here, Gayatri, that
Mm.
I feel there are two schools of thought in, say, a patient on day one or day two has bile leak in the drain or has been, and there is a school of thought which says conservative management, if no sepsis, no collection, and hoping that it will be a cystic duct or a lateral injury, it will close. And there is a school of thought which says that you need to assess the injury at the earliest because you may lose the window of repair
Window for a,
if
yeah.
you wait to see how the bile leak evolves. So I'm the person with the advent and availability of MRCP. We should do an MRCP if you're not sure what's happening and an unexpected bile leak has happened in your patient. That's very critical. And what we need to do after that is we need to assess whether continuity is there or not,
Mm.
and then get onto the algorithm. The people who are sort of who speak against
Post.
early
Mm.
evaluation or MRCP talk about the collections,
Correction.
masking the assessment, and all. I think it is uh, unfounded fear. I
Okay.
mean, if you do an MRCP, if there is a large collection, you want to know about that also.
Yeah.
So it
Mm.
will help you at least make a decision that I want to drain. And in my experience, many times when you work on the workstation and rotate the images, you would still be able to appreciate the biliary system and whether it is in continuity or not. So it's not that you are unable to make an assessment. And if in
Mm.
10-15% you are unable to do, so be
That's
it,
okay.
at least in 80% you get the information. So
True.
I, I sort of, tell everyone that just go and assess in
Mm.
whatever is unexpected recovery from a laparoscopic cholecystectomy.
Mm. That's interesting because the textbook answer that we're taught to say is the first school of thought that you said. So I think
Is
that's
it?
good. Not you, not what you taught, but I'm just saying, I'm
No,
sure.
I'm just saying, okay, I
Uh,
think it's time the textbooks have to change
yeah.
because early repair is a reality.
Mm.
We are no longer talking of no, 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 don't do. I used to be one of those who used to say no early repair. But I think with caveats, it can be
Yeah.
done. And you
Patient
still
selection.
have 85% success rate, which is good.
Good.